Brilliant. Okay, so my talk's going to be it's going to be with time, but we're going to spend a little bit of time after talking about our society and pay homage to two of our stalwart members who passed away. So I'd like to start off with my disclosures. And this slide which says that these are my ideas and not Sanofi's ideas, so that you can't blame them. Right, just those of you seen me talk before, this is the horseshoe crab, and just to remind us about COVID and thrombosis, that the horseshoe crab epitomizes for us the understanding of immunothrombosis, because you can see that it was the first organism where there's a divergence, and you can see a change that the two things happen together. So if you look on the left of your slide, you'll see the coagulation cascade, which is as various pathways. We don't have to go through them in the state of time, but on the right-hand side, you have the complement pathway. And one can see they are almost mirrored. It's a mirror image. And actually, if you look at the actual substances of each factor, you'll find they're just different Lego blocks that have been put together in a different way. So the two co-evolved, and one very seldom gets thrombosis without inflammation. One can get one very seldom gets inflammation without thrombosis. One can rarely get thrombosis without inflammation, but the two are very closely related. And COVID has brought to the fore this idea of immunothrombosis. And the idea is, and you've seen this slide before as well, those that have seen my talk, you start off with the virus, cause an alveolar infusion, and then you get this formation of these so-called nets or neutrophil extracellular traps, which then cause microthrombi and D-dimer levels to levels we'd never seen before prior to the occurrence of COVID. This then leads to a micro and a macro vascular thrombosis as seen in this unfortunate patient. So COVID, ladies and gentlemen, unfortunately is not going away. You can see the number of deaths remains sort of constantly here, and I see now that Europe has been called the new epicenter of the pandemic as the numbers are increasing quite dramatically in Europe. The number of people being vaccinated is increasing dramatically throughout the world. Sadly, in South Africa, we seem to have reached a plateau and coming down, that people aren't being vaccinated, but hopefully we're going to have the Sisonke boost, and I'll speak to that a bit later. So vaccines play an integral role in our fight against this horrible disease. But what about this idea of TTS, or thrombotic thrombocytopenia, as a result of vaccination? Well, the first clue came from Germany and Austria, where 11 patients were noted to have thrombosis with thrombocytopenia after being vaccinated, and they were vaccinated with the AstraZeneca vaccine. Of note was that in these patients, the majority had positive antibodies against platelet factor 4, and these antibodies have also been observed previously, and we've known for them for a long time in patients with HIT, heparin-induced thrombocytopenia. But of note, none of these patients had received heparin before the symptoms started. So there was a clue that something bad was going on. Subsequently, there's been a lot of cases published in the NEJM, mainly with AstraZeneca, J&J, and I'll show you later with the other vaccines as well. But thrombotic thrombocytopenia after COVID, after vaccination, is a real thing. It really does occur. What actually happens? Well, this is the theory that you have an adenovirus-based COVID-19 vaccine. You then get in your endothelial, enters into the endothelial cell, one gets spike protein expression release. And I think the vaccines are designed to produce spike proteins. These spike proteins we know are not great. They seem to activate platelet binding. In some unfortunate patients, it releases platelet factor 4, which in these patients is immunogenic. One then develops anti-platelet factor 4 antibodies. That then causes immunocomplexes. You get neutrophil activation and release of your nets, your neutrophil extracellular traps. Well, if one looks at what age is being affected, I think it's quite important to look at the darker colors of the people that didn't make it, and the lighter colors of the people that is the total, including the survivors. And we can see that it occurs generally, it seems to be below the age of 60, but can occur above the age of 60, and can occur right across the board from ages of 20 all the way through to 80, but the majority of patients seem to be below the age of 60. If one looks at when it occurs, the majority of patients will occur prior to day 28, but it can occur all the way up to day 75. So that's important to remember, that it's something that occurs quite soon. Day 5 up to day 28 is generally when it's occurring, but can be occurring very later, and one needs to take cognizance of that. Platelet counts amongst non-survivors tend to be very low. So patients with low platelet counts have got a poor chance of survival, as are patients with low fibrinogen levels. So low fibrinogen seems to be a poor prognostic indicator. This is a very important slide because you'll see that the majority of patients were actually in the cerebral veins, okay? So-called cerebral vein thrombosis, difficult diagnosis to make. Intracranial hemorrhage, DVT, pulmonary arteries, quite a lot of patients, portal veins, splanchnic vessels, but it can occur even in rare other sites, adrenal, renal, arteries of the leg or arm, coronary arteries, cerebral arteries, and interestingly, multiple sites. Other sites included ophthalmic. But this is a very, very important slide, just to look at, to put it into perspective. So this is TTS. So COVID itself can cause TTS in its own right. But if you look at the general population, the rate of TTS is about 0.4. With the J&J vaccine is 2, and this is per million COVID infections or vaccinations. So 2.2. Pfizer Pfizer's low as well. Can occur with Moderna, seems to be higher with AstraZeneca, and COVID itself can cause TTS. But remember that 20% of all their hospitalizations with COVID have got an underlying thrombotic event, mainly pulmonary arteries, as well as venous as well as DVTs. So we need to put that into perspective, that the risk, so for example here, of the J&J vaccine causing it is in the region in South Africa, is in the region of being struck by lightning. That's your statistical chance. Not that it doesn't occur, but it's very, very rare. But when it does occur, we need to know how to diagnose it and manage it. So this is from the WHO, looking at factors that seem to improve survival. And the thing that improves survival, you can see here, is the death were lowest in patients that use non-heparin anticoagulants. So that's the mainstay of our treatment. Intravenous immunoglobulin is important. Steroids don't seem to play a role. Definitely don't give platelets. And also we don't recommend giving unfractionated or low molecular weight heparins. Just a paper that came out last month, end of last month, looking at a meta-analysis of clinical cohorts with cerebral venous sinus thrombosis, and just to show that they had 370 patients, but that about a third of patients with TTS do not survive. So it's not a small disease. It's not an easy disease, but we need to be very cognizant of the fact that we need to be aware of it. And what are the predictors of poor mortality? Well, increased mortality is a low fibrinogen, so-called FAPIC score, age less than 60, a low platelet count, patients with intracerebral hemorrhage, and patients with cerebral venous thrombosis. All these are predictors of poor outcome. So we published this, the key recommendations. We published this earlier this year, and things haven't changed. Luckily, the meta-analysis that proved us to be all right. So remember, it's extremely rare, but potentially fatal. You must consider this complication because the management differs from other thrombotic events. Thrombosis with the thrombocytopenia 4 days to 16 days post-vaccination should prompt you to consider it. But in South Africa, excuse me, ladies and gentlemen, please remember that thrombocytopenia in South Africa, and a patient who's got a headache, the commonest cause is malaria or HIV or ITP. It's not a common cause, and you need to remember that malaria is a very common disease in our neck of the woods. And remember, don't give them heparin or platelet transfusions or warfarin. When do you think of it? New and unusual neurological symptoms, severe and or persistent headache. I think that's quite a critical issue, that if you look at the patients, majority of them had this unbelievably terrible headache that persists. And if your patient has got a persistent headache that doesn't undergo, you need to be aware. And it's not an easy diagnosis to make because the CAT scan will be normal. You need to do an MRI venogram. blurred vision, seizures, and or focal neurological symptoms. Those aren't hard to pick up. Symptoms or signs of thrombosis, such as persistent severe abdominal pain for the patients with splenic artery or splenic venous thrombosis, shortness of breath, chest pain, leg pain or swelling. Those are common, or tachycardia. You need to remember those. The 4T score, I don't have time to go through it in detail, but just that is published in the SAMJ, and these are look at will increase your diagnosis rate, your diagnostic rate. Just the point about, everyone talks about antiplatelet 4 antibodies. So these are complicated antibodies because, I mean, we're going through a phase now where everyone says you must do them, and they don't really understand that they haven't really been properly validated, because there are two groups of assays. There's the immunological assay. It's got a very high level of sensitivity, greater than 90%. But a lot of us walking around have got antibodies anyway, with a specificity 60 to 80%. They relatively easy to perform, and much easier to perform than the functional assays, which got a much higher specificity, but are more complex and time-consuming to perform. And we still very much in the embryonic stages of deciding which are the absolute correct tests to do to validate the TTS. In terms of management, remember, avoid platelets. Anticoagulation with heparin should be avoided. Intravenous immunoglobulin has come into the literature because it was tried in the initial patients, has now become standard of care, which is a problem for patients with limited resources, especially countries like South Africa and the rest of Africa as well. You need to monitor the platelet count closely, and we define recovery as a platelet count of 150, greater than 150. We don't believe at this stage that you should get a second dose for Sosonki boost, and we'll maybe speak to that in some more detail just now. But remember, the first line anticoagulants that should be used include the oral anticoagulants, and in our case, we've been using fondaparinux directly. Renal function, we won't talk about monitoring, we don't have time, but remember to monitor these renal functions. Anticoagulation should be continued for at least 3 months. These cases are we have had 2 cases in South Africa, a 47-year-old female with severe headache and shortness of breath, and another 43-year-old female also presented with severe headache. Both, luckily, of our patients, these 2 patients survived. I think that's a critical thing to remember, that if you find these patients early, you can manage them. As long as you think about it and make the diagnosis, they will be fine. Just to remember, it is very, very rare, because that is the issue, is about vaccination. So vaccines are a huge weapon in our armamentarium. But the vaccine hesitancy has been based on the fact that people are scared about thrombosis. In fact, my maid, when I told her she was going to be vaccinated, she was hesitant in view of the fact that she might get a thrombosis. So that the South African government stopped the vaccine rollout of the Sosonki based on this thrombosis, which was a very silly thing to do, given the fact that the only vaccine available to our healthcare workers was the J&J at the time, and it put us at risk. So to put it, we need to understand that this does occur, but it's very rare, and we need to be able to diagnose it quickly and treat it quickly. But we need to be very careful that we don't let people become anti-vaxxers or have vaccine hesitancy based on this very, very rare risk of TTS. It is a real, real risk. I want to thank Sanofi for sponsoring my talk. At the same time, I want to thank our platinum sponsors, who always come to the party to help us have this meeting. And this meeting also helps support other endeavors that our society has, including managing Gaucher's disease. And there are other sponsors, to name them: Ethicare, Sandoz, Sanofi, Cat Medical, Bayer. Our gold sponsors, Cipla, and our bronze sponsors, RJ, Pfizer, NBI, Fresenius, Ascendus, and Ampath. And we really, really appreciate their support. I'm going to take this opportunity to have the last few minutes where we're going over time, and maybe we can talk about this as our society, which I said is multiple things, but I want to thank, I want to pay special mention of 2 of our members who actually passed away this year due to, and they both were vaccinated due to COVID. And the first is Cat Medical, and the founder of Cat Medical was Keith Dotkins. He founded Cat Medical. He was an incredible friend of our society, sponsored us every year, sponsored our research into thrombosis and flying. I've known him for many years. He was an amazing father, an amazing friend. He was very fit. He got COVID. I really didn't think he would be bad. He'd been vaccinated. He used to swim for Southern Transvaal in the seniors as a play a water polo. He was a very fit man. He swam the mid-mile, and yet he succumbed despite being vaccinated. So vaccinations are no guarantee. He is shown here, and give me some license. I'm very pleased that Lord AJ is actually chairing it, because with him is our vice president's mother in this picture at our banquet, Lily Muir. We have a award, the Morris Muir Award, which is a lifetime achievement for work in thrombosis. And the first recipient of the award was AJ's late father, Vijay Kekal, who was the founder of antithrombotic treatment for venous thromboembolism. And we pay homage to him, because without him, none of us would have really been involved in thrombosis. A real amazing man. And at this banquet, we actually, the second recipient was Professor Carl Franz, who was one of my mentors. And the person that brought him and also was made a fellow at our society was Professor Kobus van Marle, who also unfortunately succumbed to COVID. Also an amazing man. He was a junior consultant when I was a junior registrar. He taught thousands of medical students. He probably had one of the best hands in the business in terms of vascular surgery, both endovascularly and open surgery. He was an amazing man, amazing teacher, and he will be sorely missed by our society. That I'd like to hand over back to our chairperson. Thank you, AJ.
Well, Barry, thank you very much for your presentation, and in particular for your words in memory of two fellows of the society, and the very sad news about their passing away. It's again a timely reminder of the devastating impact that the COVID pandemic has had globally and nationally, and indeed locally, touching so many people's lives. But it's very, very sad to reflect on the loss of those two marvelous colleagues. Now, I don't know, Barry, whether you propose to take questions now, or we should move to the next presentation.
I think we would like to take questions now, AJ, and also maybe we can speak a little bit, because I see the next meeting, and we actually gave ourselves 10 minutes because we've had a lot of questions regarding the Sasonki, regarding what to do for anticoagulation for patients being vaccinated. So maybe we can address some of those questions.
Yes, why don't you kick off, building on your local experience?
So the question I often get asked is what to do about someone who's on anticoagulation. Should they be vaccinated? And the answer is, if they're on anticoagulation, definitely, there's no reason for them not to be vaccinated if they're on anticoagulation. They should be vaccinated. The more difficult question arises for someone who has had a previous thrombosis and is not on anticoagulation, and should we offer them any prophylaxis at the time of vaccination? And generally, we are trying to limit the number of people who would not be vaccinated. So the general advice is that they should be vaccinated. And if one feels that one would offer them thromboprophylaxis for a high-risk procedure, such as long-haul travel or a surgery, minor surgery, when we offer them prophylaxis, that class of patient, we believe, purely empirically at this stage, we probably would offer them some form of thromboprophylaxis at the time of the vaccination with an adenoviral-based vector. I don't know what the feeling is in the UK.
Well, I think in general, you make a number of important points. The first is that for the overwhelming majority of patients, vaccination provides a very clear benefit, not only for the individual, but for communities and society more broadly. And therefore, what we have tried to achieve is not only double vaccination as quickly as possible, but booster vaccination now, bearing in mind the tail-off in immunity that's seen over time. I think you make the second important point that the AstraZeneca vaccine appears to be associated with a higher rate of this particular phenomenon of thrombosis, and therefore, in general, is not being now offered as a third booster dose in the United Kingdom. The Moderna or Pfizer vaccines are the two that are being offered as a booster dose now for the third dose of the vaccine. But there's a very interesting question here that's particularly pertinent to South Africa, and that is the question of HIV positive patients and theoretical risk around the thrombosis, thrombocytopenic syndrome in these patients with regard to vaccination. What's your view about that?
So at this stage, we're saying vaccinate. We don't believe, because some of them have a mild thrombocytopenia anyway, and we believe their risk will be greater if they have any form of vaccine hesitancy. So we're vaccinating all the HIV patients. I have take the opportunity, because I know that we're going to be working together, J&J. We're in the final processes of getting them to agree. I'm hoping Abid is actually online and listening to us, because we've been battling for some time now to get agreement. But we are in the final process of getting a study up and running with the help of TRI, where we're going to be instituting 5 sites in South Africa, where we will be investigating the incidence of TTS and more importantly, any thrombotic events occurring, because there's very limited data we have for for VTE in Africa. And if the project is successful, then J&J have undertaken to then expand it into the rest of Africa. So we can start to get good data on thrombosis, especially around vaccination as well. But that will be our handle to get into Africa and actually to understand thrombotic risk, especially in the conjunction and in the presence of HIV.
Now, I think that's going to be a marvelous study and vitally important locally and then across the region eventually in the fullness of time. There's a question here about aspirin and the particular thrombocytopenic risk. What's your view about the use of aspirin in these patients?
There is no data to support its use whatsoever. Absolutely no data whatsoever to support its use, and we wouldn't really recommend it. And tell everyone to take an aspirin and go home. There's no data to say it helps, and people that have been on aspirin haven't had a lower prevalence. So it's a rare complication. There is no test we can do that people are doing right or wrong that causes TTS. Just make sure that the clinicians are very aware of it. And we are going to see, because we're about to embark on this Sonki boost study for the healthcare workers, where we're going to be vaccinating 500,000 people again, giving them a booster J&J. So we will expect to see 1 or 2 TTSs again. So we will see 1 or 2 TTSs, but in light of the 500,000 people that hopefully we're going to be protecting from the 4th wave, I don't think, I think it's very small, and we just need to be aware. And if we pick them up early, we should be able to manage them successfully. And if you do have any questions or you do have any cases, please don't hesitate to contact me directly, and we will either help you see the case or transfer the case and help you manage it.
Okay, just two more quick questions. The question of the J&J vaccine over potentially the Pfizer vaccine in patients with previous TTP.
Okay, well, the point is, if you've had TTP, we are saying don't be vaccinated again. We don't. If you've had TTP, it's very rare. We've had 2 patients in South Africa, 4 maybes, but 2 definites. So it's so rare. We don't believe you should be vaccinated. So I wouldn't vaccinate someone with TTP or TTS. Sorry,
TTP here.
TTP. So we've had 2 cases of TTP as well. One patient that fortunately passed away. We don't recommend, if you've had TTP, which is also a very rare condition, that you be revaccinated. If you've had TTP and it's been associated, we don't believe you should be vaccinated.
Okay, and then finally, the question of treatment of COVID-19 infection related to thrombosis. I assume that is anticoagulant treatment. So the thrombosis is the background of COVID-19.
Yeah, we anticoagulate those patients, and if they have a thrombosis, we anticoagulate them fully, and we monitor their levels.
Great.